Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Thank you for joining us for episode 1 of this clinical clip titled Key Breakthroughs in the Treatment of Primary Biliary Cholangitis from the European Association for the Study of Liver EASL Congress 2025 in Amsterdam. My name is Dr. Nancy Reau, and I am the section chief and professor of medicine at Rush University Medical Center. In this clip, I will highlight key data presented at the conference in Amsterdam. There were 2 late-breaker posters presenting data on the PPAR alpha-delta agonist elafibranor. The first, presented by Mark Swain, elafibranor impacts inflammatory, fibrotic, and symptom-associated markers in patients with primary biliary cholangitis, proteomic results from the ELATIVE trial. This was a really interesting analysis where they looked at longitudinal protein expression profiles at week 0 or baseline, 26, and 52 using an Olink panel that covered over 5,500 proteins. This showed that a network of over 20 proteins involved in hepatic inflammation has statistically significant changes of expression in the elafibranor-treated patients with biochemical response at week 52. This network is known to be involved in immune cell adhesion and inflammatory regulation, and it maps to immune modulation and fibrosis pathways, which means that it lines up with what you would expect to see change in someone who is having a good biochemical response. It also showed biomarkers that were associated with itching and fibrosis that were significantly downrated. So this doesn't necessarily change the dial right now, but these biomarkers can help clarify mechanisms of the disease and help identify additional treatment options, plus might be able to show earlier signs that line up with histologic endpoints. So we're really excited about new biomarkers. The next late breaker poster presented by David Jones, elafibranor improves fatigue versus placebo in patients with primary biliary cholangitis with limited correlation with pruritus, an analysis from the phase 3 ELATIVE trial. First, there are several scales that we can use in clinical research, and they used 2 to address fatigue. The PSSF 7A scale, and this showed at baseline 44% of patients in the ELATIVE action arm and 35% in the placebo arm had moderate to severe fatigue. So not all patients are severely fatigued. By week 52, using this same scale, 43% of the patients on active agent versus 31% receiving placebo had improved to mild or normal fatigue. But equally important, nearly 67% of patients receiving elafibranor had a meaningful improvement in itching compared to only about less than a third in the placebo arm. An alternative scale, the PBC-40 fatigue domain, showed slightly different results. Here, 56% and 57% in each arm had severe, moderate to severe fatigue. This score also showed a significant improvement by week 52, with 22.6% in the elafibranor versus 15.4% in the placebo arm, having improved to mild to no fatigue. On top of that, nearly 40% receiving elafibranor had an improvement that was statistically significant compared to 27% in the placebo arm. More importantly, baseline fatigue and pruritus PRO scores only had a weak correlation, suggesting that pruritus was not the main driver of fatigue in this analysis. Similarly, changes in fatigue and pruritus PROs from baseline to week 52 did not demonstrate a strong correlation, and that they could improve independently of one another. So although we certainly recognize that itchiness impacts sleep, it did not seem that the pruritus was only sleep related, as the fatigue and pruritus seemed to respond differently. Keeping with the theme of extrahepatic manifestations of PBC, Gideon Hirschfield had an oral presentation on an IBAT inhibitor. Lenariximab significantly improves cholestatic pruritus in primary biliary cholangitis, result of the pivotal phase 3 GLISTEN trial. Here, they described the results of the GLISTEN trial, which was a phase 3 study investigating the efficacy and safety of the ileal bile acid transport inhibitor, or IBAT, lenariximab, for pruritus and PBC. This was double-blinded, randomized, placebo-controlled in patients with PBC and moderate to severe pruritus. So here, everyone had moderate to severe pruritus, and they received either the IBAT inhibitor 40 milligrams or placebo twice a day. The primary endpoint was change from baseline in worst itch over 24 weeks, and they had 238 patients randomized, most of which were female, and importantly, 52% had an alkaline phosphatase that was less than 1.67 times the upper limit of normal, really showing that this is for symptom treatment, not necessarily targeting patients that were not in biochemical remission. Nearly half of these were also on stable therapy for pruritus. In the 24-week trial, pruritus improved significantly in the intervention arm compared to placebo. Also, the effect was rapid. At week 2, it was already superior to the placebo. It also improved pruritus-related sleep interference. So here, sleep interference is improving, and that you would imagine that with better sleep, that might impact fatigue, although that was not measured here. And although multiple other measures were reported, one of the easiest to understand was that 55% of the IBAT inhibitor-treated patients reported their pruritus as very much improved, compared to 30% in the placebo arm. There are side effects associated with IBAT inhibitors, and 61% of patients did have diarrhea compared to 18% of the placebo arm, and 18% had abdominal pain versus 3%. However, very few, only 4% of the patients actually discontinued the agent because of diarrhea. Biochemical response is ultimately the goal for most of our interventions, and we recognize that many patients do not achieve this with one agent, and nearly 50% may not achieve complete biochemical response with 2 agents. So third-line therapy is considered important, or at least something that should be thought about in a sizable number of our individuals. Here, a poster presented by Nadir Abbas looked at combining abetacolic acid, or OCA, and off-label thyroid therapy in those that had not had biochemical response. And they compared either switching from OCA to a fibrate to add-on therapy from an OCA to a fibrate. Now, this is looking at 2 agents that are not our only options right now, but given the fact that when the trial was enrolled, these were the things that were available to the study. And just reminding everyone that fibrates are off-label. In this study, it could either have been fenofibrate or benzofibrate, as there were multiple fibrate options that were available to the study investigators. The goal of the study was to compare biochemical response rates, not non-hepatic symptoms, of either combination therapy or of a switch regimen, where OCA was stopped and then substituted for a fibrate in a biochemical non-responder. This was conducted in the UK in 5 high-volume liver centers, and biochemical response was defined by the POISE criteria, or alkaline phosphatase less than 1.67 times the upper limit of normal, along with an alkaline phosphatase reduction of at least 15% from pre-treatment values in a normal bilirubin. Secondary outcomes included alkaline phosphatase normalization and then liver-related clinical events. They recruited 240 patients who initiated abetacolic acid as a second-line therapy, and they were observed for 4 years. 45 initiated fibrates as an add-on therapy, and 74 switched from OCA to a fibrate. And again, biochemical response, according to POISE criteria, was met in an increasingly number of patients over the 4 years. So in the add-on group, it was 31, 44, 85, and 91% of the patients at 4 years. But when you looked at the switch group, it was 16, 34, 42, and only 43% at the end of the 4 years. On top of that, alkaline phosphatase did normalize at the end of 4 years in 52% of the add-on compared to 35% of the switch. And clinical events were similar throughout both arms. So the study authors did conclude that biochemical response rates under an OCA plus fibrate therapy were better than the stopping and switching from OCA to fibrate. But of course, the numbers are still small. Next, I want to go through 2 oral presentations on Seladelpar. First, there was a presentation by Alejandra Villamil on addressing the efficacy and safety of Seladelpar in patients who had previously been treated with fibrates or abetacolic acid. Remember, Seladelpar is a first-in-class delta PAR selective PPAR agonist, and it is indicated in the treatment of primary cholangitis in combination with ursodeoxycholic acid in patients with an inadequate response to ursodeoxycholic acid as monotherapy. They looked at two different studies, the RESPONSE trial, which was a phase 3 randomized placebo-controlled clinical trial in patients with inadequate response. And then when they completed the RESPONSE trial, they could roll over to the ASSURE trial, which was an open label long-term phase 3 safety trial. So this is looking at month 18 of the RESPONSE trial and month 6 of the ASSURE, because they were on placebo and then could roll over or rolled over from intervention. And this was in patients that either had used fibrate or A-beta-cholic acid. Now, fibrates and A-beta-cholic acid were prohibited during the study period for 6 weeks, so all patients had to have a washout of their first therapy, and then they were entered into the clinical trial. They did look at efficacy, which included the percentage of patients that had complete biochemical response, which was defined as an alkaline phosphatase less than 1.67 times the upper limit of normal, along with a decrease of at least 15% from baseline, and a total bilirubin of less than or equal to upper limit of normal. And they also looked at safety. There were 16 continuous seladelpar and 11 crossover patients that had used fibrates or A-beta-cholic acid. So you can see that these numbers are small, and they did not differentiate between individuals who had had fibrates compared to A-beta-cholic acid, and some might have actually had both. When you looked at the results, 60% of those that had had a prior fibrate or A-beta-cholic acid actually achieved complete biochemical response compared to 62% of those that had not. So you can see that failing a prior second-line therapy did not change the efficacy of using seladelpar in urso patient that had not met complete biochemical response. Among crossover patients, so these were the individuals that had placebo and then moved over for 6 months assessment, 64% in those that had had prior fibrate or OCA use compared to 78% achieved complete biochemical response after 6 months. So they did conclude that prior use of fibrates or A-beta-cholic acid achieved similar sustained biochemical response with seladelpar compared to patients who had reported no use, and that seladelpar did appear safe and well tolerated in this subgroup. The second study was presented by Bettina Hansen. Seladelpar treatment of patients with primary biliary cholangitis improves the GLOBE score and predicts improved transplant-free survival. The GLOBE score is not necessarily something that we use in clinical practice. It's a score that really estimates prognosis or transplant-free survival. For those that you have not used it, there's a nice little app that you can calculate it, and it's based on your albumin, your total bilirubin, the age at the start of ursodeoxycholic acid, and alkaline phosphatase. And then they assess response after 1 year or other years. And although this has been validated in ursodeoxycholic acid, they did use this score at the onset of seladelpar. So they would be using at age they used at the beginning of seladelpar. They calculated it over time. The patients were followed for 2 years, and the GLOBE had a steep decline and then stabilized. The placebo crossover, which was allowed, also showed the same thing. So there were significant improvements in the GLOBE score, which were then maintained. And this would predict a 5 to 10% improvement in transplant-free survival. So the authors did conclude that seladelpar treated patients with PBC improved GLOBE score, and that should impact long-term transplant-free survival. But of course, we will need real-world data eventually. In closing, I want to thank you again for joining us on episode 1 of this clinical clip titled Key Breakthroughs in the Treatment of Primary Biliary Cholangitis from EASL Congress 2025. Please be sure to click on the landing page for this activity to claim your AMA, NCC, ACPE credit, and access downloadable slides. Also, please join us for episode 2, coming soon.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.